13 Symptoms of esophageal disease. Kenneth R. Duvall. Common symptoms that affect the esophagus include dysphagia, odynophagia, globus sensation, hiccups, chest pain, heartburn, regurgitation, and a number of supraesophageal complaints that have been attributed to gastroesophageal reflux. A carefully taken history can clarify many of these symptoms and is followed by selected testing, therapeutic trials, or both. Dysphagia is either proximal or distal and can be to solids only or to liquids and solids. Barium testing, manometry, and endoscopy are appropriate tests in a patient with dysphagia. Odynophagia usually indicates mucosal disease and should lead to endoscopy in most situations. The evaluation of globus sensation and hiccups usually does not yield a specific disorder, and the management is thus challenging. Chest pain can originate from the esophagus and frequently responds to gastric acid suppression. If reflux is not present, the evaluation and treatment of chest pain become challenging. Typical, heartburn and regurgitation, and extraesophageal symptoms potentially caused by GERD may respond to a diagnostic and therapeutic trial of acid suppression. Ambulatory pH testing is the best method to confirm reflux in these patients. Many of these esophageal symptoms may also occur in a patient with no objective evidence of pathology and are then considered and treated as functional disorders. Symptoms related to the esophagus are among the most common in general medical as well as gastroenterologic practice. For example, dysphagia becomes more common with aging and affects up to 15% of persons age 65 or older. 1 Heartburn, regurgitation, and other symptoms of GERD are also common. A survey of healthy subjects in Olmsted County, Minnesota, found that 20% of persons, regardless of gender or age, experienced heartburn at least weekly. 2 Mild symptoms of GERD rarely indicate severe underlying disease but must be addressed, especially if they have occurred for many years. Frequent or persistent dysphagia or odynophagia suggests an esophageal problem that necessitates investigation and treatment. Other less specific symptoms of possible esophageal origin include globus sensation, chest pain, 168 belching, hiccups, rumination, and extraesophageal complaints like wheezing, coughing, sore throat, and hoarseness, especially if other causes have been excluded. A major challenge in evaluating esophageal symptoms is that the degree of esophageal damage often does not correlate well with the patient's or physician's impression of symptom severity. 3 This is a particular problem in older patients, in whom the severity of gastroesophageal reflux-induced injury to the esophageal mucosa is increased despite an overall decrease in the severity of symptoms. 4 Dysphagia, from the Greek dys, difficulty, disordered, and phagia, to eat, refers to the sensation that food is hindered in its passage from the mouth to the stomach. Most patients complain that food sticks, hangs up, or stops, or they feel that the food just won't go down right. Occasionally they complain of associated pain. If asked, "Do you have trouble swallowing?" some patients with dysphagia in the lower esophagus will actually say no because they may only think of swallowing as the transfer of food from the mouth to the esophagus. Patients with a dilated esophagus, particularly due to achalasia, may incorrectly interpret dysphagia as regurgitation or even vomiting. Dysphagia always indicates malfunction of some type in the oropharynx or esophagus, although associated psychiatric disorders can amplify this symptom. Pathophysiology: inability to swallow is caused by a problem with the strength or coordination of the muscles required to move material from the mouth to the stomach or by a fixed obstruction somewhere between the mouth and stomach. Occasionally patients may have a combination of the two processes. The oropharyngeal swallowing mechanism and the primary and secondary peristaltic contractions of the esophageal body that follow usually transport solid and liquid boluses from the mouth to the stomach within 10 seconds. If these orderly contractions fail to develop or progress, the accumulated bolus of food distends the esophageal lumen and causes the discomfort associated with dysphagia. In some patients, particularly older adults, dysphagia is the result of low-amplitude primary or secondary peristaltic activity that is insufficient to clear the esophagus. High-resolution manometry has identified areas of weak or absent peristalsis of varying lengths, peristaltic gaps, that may explain dysphagia in some patients who have a normal conventional manometry result. 5 Other patients have a primary or secondary motility disorder that grossly disturbs the orderly contractions of the esophageal body. Because these motor abnormalities may not be present with every swallow, dysphagia may wax and wane. See also Chapter 44. Mechanical narrowing of the esophageal lumen may interrupt the orderly passage of a food bolus despite adequate peristaltic contractions. Symptoms vary with the degree of luminal obstruction, associated esophagitis, and type of food ingested. The normal esophagus distends in advance of a bolus's arrival. Patients with a poorly distensible esophagus, e.g., due to eosinophilic esophagitis or radiation esophagitis, may experience dysphagia even though the esophagus does not appear to be narrowed during EGD or barium swallow. See later. 6 Although minimally obstructing lesions cause dysphagia only with large poorly chewed boluses of foods like meat and dry bread, lesions that obstruct the esophageal lumen completely lead to symptoms with solids and liquids. GERD may produce dysphagia related to an esophageal stricture, but some patients with GERD clearly have dysphagia in the absence of a demonstrable stricture, and perhaps even without esophagitis. 7 Abnormal sensory perception in the esophagus may lead to the feeling of dysphagia even when the bolus has cleared the esophagus. Because some normal test subjects experience the sensation of dysphagia when the distal esophagus is distended by a balloon, as well as by other intraluminal stimuli, an aberration in visceral perception could explain dysphagia in patients who have no definable cause. 8 This mechanism may also apply to amplification of symptoms in patients with spastic motility disorders, in whom the frequency of psychiatric disorders is increased. 9 Differential diagnosis and approach when faced with a patient who complains of dysphagia. The healthcare provider should approach the problem in a systematic way. Most patients can localize dysphagia to the upper or lower portion of the esophagus, although occasional patients with a distal esophageal cause of dysphagia will present with symptoms referred only to the suprasternal notch or higher. The approach to dysphagia can be divided into oropharyngeal and esophageal dysphagia, although considerable overlap may occur in certain groups of patients. An attempt should be made to determine whether the patient has difficulty only with solid boluses or with both liquids and solids. Oropharyngeal dysphagia with processes that affect the mouth, hypopharynx, and upper esophagus. The patient is often unable to initiate a swallow and must repeatedly attempt to swallow. Patients frequently describe coughing or choking when they attempt to eat. The inability to propel a food bolus successfully from the hypopharyngeal area through the upper esophageal sphincter, UES, into the esophageal body is called oropharyngeal or transfer dysphagia. The patient is aware that the bolus has not left the oropharynx and locates the site of symptoms specifically to the region of the cervical esophagus. Dysphagia that occurs immediately or within 1 second of swallowing suggests an oropharyngeal abnormality. At times, a liquid bolus may enter the trachea or nose rather than the esophagus. Some patients describe recurrent bolus impactions that require manual dislodgement. In severe cases, saliva cannot be swallowed, and the patient drools. Families are tempted to perform the Heimlich maneuver in such instances, but this is not appropriate unless the bolus is producing airway compromise. They should be informed that if the patient can speak, the airway is functional and forcing an esophageal bolus proximally may cause rather than prevent aspiration. Abnormalities of speech like dysarthria or nasal speech may be associated with oropharyngeal dysphagia. Systemic neurologic and neuromuscular conditions such as Parkinson's disease, amyotrophic lateral sclerosis, and polymyositis can present with dysphagia as a predominant and occasionally only symptom. Oral pathology should be considered as well. Poor teeth or poorly fitting dentures may disrupt mastication and result in an attempt to swallow an overly large or poorly chewed bolus. Loss of salivation caused by medications, radiation, or primary salivary dysfunction may result in a bolus that is difficult to swallow. Recurrent bouts of pulmonary infection may reflect spillover of food into the trachea because of inadequate laryngeal protection. Hoarseness may result from recurrent laryngeal nerve dysfunction or intrinsic muscular disease, both of which cause ineffective vocal cord movement. Weakness of the soft palate or pharyngeal constrictors causes dysarthria and nasal speech as well as pharyngonasal regurgitation. Swallowing associated with a gurgling noise may be described by patients with Zinker diverticulum. Finally, unexplained weight loss may be the only clue to a swallowing disorder. Patients avoid eating because of the difficulties encountered. Potential causes of oropharyngeal dysphagia are shown in box 13.1. After an adequate history is obtained, the initial test is a carefully conducted barium radiographic examination, which is optimally performed with the assistance of a swallowing therapist, modified barium swallow. If the study is normal with liquid barium, the examination is repeated after the patient is fed a solid bolus to bring out the patient's symptoms and thereby aid in localizing any pathology. If the oropharyngeal portion of the study is normal, the remainder of the esophagus should be examined. The modified barium swallow usually identifies the problem and directs initial therapy. Esophageal dysphagia. Most patients with esophageal dysphagia localize their symptoms to the lower sternum or, at times, the epigastric region. A smaller number of patients describe a sensation in the suprasternal notch or higher even though the bolus stops in the lower esophagus. Esophageal dysphagia can frequently be relieved by various maneuvers like repeated swallowing, raising the arms over the head, throwing the shoulders back, and using the Valsalva maneuver. Motility disorders or mechanical obstructing lesions can cause esophageal dysphagia. To clarify the origin of symptoms of esophageal dysphagia, the answers to 3 questions are crucial. What type of food or liquid causes symptoms? Is the dysphagia intermittent or progressive? Does the patient have heartburn? On the basis of these answers, distinguishing the several causes of esophageal dysphagia, box 13.2, as a structural, mechanical, box 131 causes of oropharyngeal dysphagia neuromuscular ** amyotrophic lateral sclerosis, ALS, Lou Gehrig disease, CNS tumors, benign or malignant, idiopathic UES dysfunction manometric dysfunction of the UES or pharynx multiple sclerosis muscular dystrophy myasthenia gravis Parkinson disease polymyositis or dermatomyositis post-polio syndrome stroke. Thyroid dysfunction structural carcinoma infections of pharynx or neck osteophytes and other spinal disorders prior surgery or radiation therapy proximal esophageal web thyromegaly Zinker diverticulum * any disease that affects striated muscle or its innervation may result in dysphagia. Many manometric disorders, hypertensive and hypotensive UES, abnormal coordination and incomplete UES relaxation, have been described, although their true relationship to dysphagia is often unclear. UES, upper esophageal sphincter. Box 132 common causes of esophageal dysphagia neuromuscular, motility, disorders primary achalasia distal esophageal spasm hypercontractile, jackhammer, esophagus hypertensive lay nutcracker, high pressure, esophagus other peristaltic abnormalities * secondary Chagas disease reflux-related dysmotility scleroderma and other rheumatologic disorders structural, mechanical, disorders intrinsic carcinoma and benign tumors diverticula eosinophilic esophagitis esophageal rings and webs, other than Schatzki ring, foreign body lower esophageal, Schatzki, ring medication-induced stricture peptic stricture extrinsic mediastinal mass spinal osteophytes vascular compression * peristaltic abnormalities include absent peristalsis and weak peristalsis, as well as hypertensive peristalsis, nutcracker esophagus. Lay, lower esophageal sphincter. Or a neuromuscular, motility, defect and postulating the specific cause are often possible, Fig 13.1. Patients who report dysphagia with solids and liquids are more likely to have an esophageal motility disorder than mechanical obstruction. Achalasia is the prototypical esophageal motility disorder. In addition to dysphagia, many patients with achalasia complain of bland regurgitation of undigested food, especially at night, and weight loss. By contrast, patients with a spastic motility disorder like distal esophageal spasm may complain of chest pain and sensitivity to hot or cold liquids. Patients with scleroderma, systemic sclerosis, involving the esophagus usually have Raynaud phenomenon and may have heartburn and regurgitation. In these patients, complaints of mild dysphagia can be due to a motility disturbance or esophageal inflammation, but severe dysphagia almost always signals the presence of a peptic stricture or, less commonly, malignancy. See chapters 37, 44, 46, and 48. In patients who report dysphagia only after swallowing solid foods and never with liquids alone, mechanical obstruction should be suspected. A luminal obstruction of sufficiently high grade, however, may be associated with dysphagia for solids and liquids. If food impaction develops, the patient frequently must regurgitate for relief. If a patient continues to drink liquid after the bolus impaction, large amounts of that liquid may be regurgitated. When asking about liquid dysphagia, it is important to distinguish the patient who has true liquid dysphagia only when drinking from the patient who has liquid dysphagia only after a solid bolus has become impacted. Hypersalivation is common during an episode of dysphagia and provides even more liquid to regurgitate. Episodic and non-progressive dysphagia without weight loss is characteristic of an esophageal web or a distal esophageal, Schatzky, ring. Point 10. The first episode typically occurs during a hurried meal, often with alcohol. The patient notes that the bolus of food sticks in the lower esophagus. It can often be passed by drinking large quantities of liquids. Many patients finish the meal without difficulty after the obstruction is Fig 13.1 diagnostic algorithm for patients with dysphagia. For details of the approach to each type of dysphagia, see text and boxes. Less specific motility disorders include nutcracker esophagus, distal esophageal spasm, and other disorders of ineffective esophageal motility. Modified from Castel Du, Donner M.W. Evaluation of dysphagia. A careful history is crucial. Dysphagia 1987, 2:65-71. Relieved. Initially, an episode may not recur for weeks or months, but subsequent episodes may occur frequently, see chapter 43. Daily dysphagia, however, is likely not caused by a lower esophageal ring. If solid food dysphagia is clearly progressive, the differential diagnosis includes peptic esophageal stricture and carcinoma. Benign esophageal strictures develop in some patients with GERD, see chapter 46. Most of these patients have a long history of associated heartburn. Weight loss seldom occurs in patients with a benign lesion, because these patients have a good appetite and convert their diet to high-calorie soft and liquid foods to maintain weight. Patients with carcinoma differ from those with peptic stricture in several ways. As a group, patients with carcinoma are older and present with a history of rapidly progressive dysphagia. They may or may not have a history of heartburn, and heartburn may have occurred in the past but not the present. Most have anorexia and weight loss, see chapter 48. True dysphagia may be seen in patients with pill, caustic, or viral esophagitis, but the predominant complaint of patients with these acute esophageal injuries is usually odynophagia, see chapter 45. Patients may present with a food bolus impaction, and eosinophilic esophagitis should be considered in the differential diagnosis of all patients who present with dysphagia, see chapter 30. Point 11. Eosinophilic esophagitis was initially described in young adult men, but subsequent series have found this disorder in both sexes and all age groups. Point 12. Surgical causes of dysphagia include prior fundoplication or other surgery at the esophagogastric junction, and bariatric surgery can also present with dysphagia, see chapter 8. Such dysphagia can be due to mechanical obstruction, but there have also been reports of motility disturbances after surgery up to and including a manometric appearance consistent with achalasia. Point 13. After a focused history of the patient's symptoms is obtained, a barium study, including a solid bolus challenge, is often advocated as the first test. Alternatively, many experts have advocated endoscopy as the first test, especially in patients with intermittent dysphagia for solid food suggestive of a lower esophageal ring or with pronounced reflux symptoms. Choice of the initial test should be based on local expertise and the preference of the individual healthcare provider. If the barium examination demonstrates an obstructive lesion, endoscopy is usually done for confirmation and biopsy. Endoscopy also permits dilation of strictures, rings, and neoplasms. Empirical dilation of the esophagus is often performed in patients with a history suggestive of obstructive dysphagia and a normal endoscopic examination. 14 But the safety and efficacy of this approach have been questioned. 15 If the barium examination is normal, esophageal manometry is often performed to look for a motility disorder. Some patients with reflux symptoms and dysphagia, a normal barium study or endoscopy, or both, will respond to a trial of gastric acid suppressive therapy. Odynophagia-like dysphagia, odynophagia, or painful swallowing, is specific for esophageal involvement. Odynophagia may range from a dull retrosternal ache on swallowing to a stabbing pain with radiation to the back so severe the patient cannot eat or even swallow his or her own saliva. Odynophagia usually reflects an inflammatory process that involves the esophageal mucosa or, in rare instances, the esophageal muscle. The most common causes of odynophagia include caustic ingestion, pill-induced esophagitis, radiation injury, and infectious esophagitis, candida, herpes virus, CMV Box 13.3, see chapters 41 and 45. In these diseases, dysphagia may also be present, but pain is the dominant. Box 133 Causes of odynophagia: caustic ingestion, acid-alkali, pill-induced injury, alendronate and other bisphosphonates, aspirin and other NSAIDs, imprenium bromide, iron preparations, potassium chloride, especially slow-release form, quinidine tetracycline and its derivatives, zidovudine, infectious esophagitis, viral CMV, EBV, HIV, HSV, bacterial mycobacteria, tuberculosis or Mycobacterium avium complex, fungal Candida albicans, histoplasmosis, protozoan cryptosporidiosis, pneumocystis jirovesi, severe reflux esophagitis, esophageal carcinoma complaint. Odynophagia is an infrequent complaint of patients with GERD and, when present, is usually associated with severe ulcerative esophagitis. In rare cases, a non-obstructive esophageal carcinoma can produce odynophagia. Because many of the diseases that cause odynophagia have associated symptoms and signs, a carefully taken history can often suggest a diagnosis. For example, a teenager who takes tetracycline for acne and in whom odynophagia develops most likely has pill-related dysphagia. An immunocompromised patient with odynophagia is likely to have an infectious cause, see chapters 35, 36, and 45, and a patient with GERD is likely to have severe peptic esophagitis. EGD to visualize and obtain biopsy specimens of the esophageal mucosa is required to confirm a specific diagnosis in most patients with odynophagia. Globus sensation. Globus sensation is a feeling of a lump or tightness in the throat, unrelated to swallowing. Up to 46% of the general population experience globus sensation at one time or another. 16 The sensation can be described as a lump, tightness, choking, or strangling feeling, as if something is caught in the throat. Globus sensation is present between meals, and swallowing of solids or large liquid boluses may give temporary relief. Frequent dry swallowing and emotional stress may worsen this symptom. Globus sensation may occur after a traumatic event like swallowing a rough bolus, fish bone, or even after endoscopy despite the lack of identifiable mucosal injury if intubation with the endoscope was psychologically traumatic. 17 Globus sensation should not be diagnosed in the presence of dysphagia or odynophagia. Pathophysiology. Detection of physiologic and psychological abnormalities in patients with globus sensation has been inconsistent and controversial. Although frequently suggested, manometrically detectable UES dysfunction has not been identified directly as the cause of globus sensation, nor does the UES appear to be hyper-responsive to esophageal distension, acidification, or mental stress. 18 Furthermore, esophageal distension can cause globus sensation unrelated to a rise in UES pressure, and stress can induce an increase in UES pressure that is not associated with globus sensation in normal subjects and in patients who complain of globus sensation. Heartburn has been reported in up to 90% of patients with globus sensation. 19 Yet documentation of esophagitis or abnormal gastroesophageal reflux by esophageal pH monitoring is found in fewer than 25%, see later. Balloon distension of the esophagus produces globus sensation at lower balloon volumes in globus sufferers than in controls, This finding suggests the perception of esophageal stretch may be heightened in some patients with globus sensation. Psychological factors may be important in the genesis of globus sensation. The most common associated psychiatric diagnoses include anxiety, panic disorder, depression, hypochondriasis, somatic symptom disorder, and introversion. 20 Indeed, globus sensation is the fourth most common symptom in patients with somatic symptom disorder. See Chapter 23. 21 A combination of biological factors, hypochondriacal traits, and learned fear after a choking episode provides a framework for misinterpretation of the symptoms and intensifies the symptoms of globus or the patient's anxiety. 22 Approach The approach to globus sensation involves excluding a more sinister underlying disorder and then offering symptom-driven therapy. A nasal endoscopy to rule out pharyngeal pathology and a barium swallow to rule out a fixed pharyngeal lesion are often helpful. 23 Patients with globus sensation often have erythema and other changes in the larynx that may be interpreted as consistent with laryngopharyngeal reflux. Most reflux experts consider these changes to be nonspecific and not diagnostic of pathologic reflux. 24 If a patient has heartburn, gastric acid suppressive therapy is the first step, but reflux may be the cause of globus sensation even in the absence of heartburn. A trial of a PPI, usually given twice daily before meals, is diagnostic and therapeutic in some patients. Ambulatory reflux monitoring may show acid or non-acid reflux in some patients. See Chapter 46. 25 Alternatively, if the patient has obvious anxiety and has already failed a trial of acid suppression, therapy directed toward the psychological component of the problem should be considered. Hiccups The symptom of hiccups, syngitis, is caused by a combination of diaphragmatic contraction and glottic closure. Therefore, it is not classically an esophageal symptom but is a common complaint in primary care and gastroenterology. Most cases of hiccups are idiopathic, but the symptom has been associated with many conditions, trauma, masses, infections, uremia, that affect the central nervous system, thorax, or abdomen. Hiccups associated with uremia may be particularly difficult to control. GI causes include GERD, achalasia, gastropathies, and peptic ulcer. Hiccups often occur after a large meal. Because most cases are self-limited, intervention is not usually required. The evaluation of chronic or difficult cases should include select tests to exclude esophageal, thoracic, or systemic diseases. Because GERD has been associated with hiccups, a trial of gastric acid suppressive therapy may be reasonable in some patients. 26 Many agents have been used to suppress hiccups, with varying success: chlorpromazine, nifedipine, haloperidol, phenytoin, metoclopramide, baclofen, and gabapentin. 27 Alternative modalities, including acupuncture, have also been tried in refractory cases. 28 Ablation and stimulation of the phrenic nerve have been reported but should only be considered in truly refractory cases in which the patient's quality of life is severely reduced by the condition and only after all other less invasive approaches have been attempted. 29 Chest pain of esophageal origin. Chest pain of esophageal origin may be indistinguishable from angina pectoris to patients and their healthcare providers. The esophagus and heart are anatomically adjacent and share innervation. In fact, once cardiac disease is excluded, esophageal disorders are probably the most common causes of chest pain. Of the approximately 1 million patients in the USA who undergo coronary angiography yearly for presumed cardiac pain, almost 40% have normal epicardial coronary arteries. In many of these persons, esophageal disease is implicated as a cause of pain. 31 Esophageal chest pain is usually described as a squeezing or burning substernal sensation that radiates to the back, neck, jaw, or arms. Although not always related to swallowing, the pain can be triggered by ingestion of hot or cold liquids. It may awaken the patient from sleep and can worsen during periods of emotional stress. The duration of pain ranges from minutes to hours and may occur intermittently over several days. Although pain can be severe, causing the patient to become ashen and perspire, it often abates spontaneously and may be eased with antacids. Occasionally the pain is so severe that narcotics or nitroglycerin are required for relief. Close questioning reveals that most patients with chest pain of esophageal origin have other esophageal symptoms, but chest pain is the only esophageal complaint in about 10% of cases. 32 The clinical history does not enable the physician to reliably distinguish a cardiac from an esophageal cause of chest pain. In fact, gastroesophageal reflux may be triggered by exercise. 33 And cause exertional chest pain that mimics angina pectoris, even during treadmill testing. Features suggestive of an esophageal origin include pain that continues for hours, is retrosternal without lateral radiation, interrupts sleep or is related to meals, and is relieved with antacids. The presence of other esophageal symptoms helps establish an esophageal cause of pain. However, as many as 50% of patients with cardiac pain also have one or more symptoms of esophageal disease. 34 Furthermore, relief of pain with sublingual nitroglycerin has been shown not to be specific for a coronary origin of pain. 35 Cardiac and esophageal disease increase in frequency as people grow older, and both problems may not only coexist but also interact to produce chest pain. The esophagus can be blamed for musculoskeletal pain, so the examination should include careful palpation of the chest wall. Pathophysiology. The specific mechanisms that produce esophageal chest pain are not well understood. Chest pain that arises from the esophagus has commonly been attributed to stimulation of chemoreceptors, by acid, pepsin, or bile, or mechanoreceptors, by distension or spasm. Thermoreceptors, stimulated by cold, may also be involved. Gastroesophageal reflux causes chest pain primarily through acid-sensitive esophageal chemoreceptors. Acid-induced dysmotility may be a cause of esophageal pain. Early studies showed that perfusion of acid into the esophagus in patients with gastroesophageal reflux increases the amplitude and duration of esophageal contractions and induces simultaneous and spontaneous contractions, with the occurrence of pain. 36 Distal esophageal spasm has also been demonstrated during spontaneous acid reflux. Subsequent studies with modern equipment, however, have shown that such changes in motility are rare. 37 In addition, studies using 24-hour ambulatory esophageal pH and motility monitoring have shown that the association between abnormal motility and pain is uncommon, and that spontaneous acid-induced chest pain is rarely associated with abnormalities in esophageal motility. 38, 39 Patients with chest pain suspected to be esophageal in origin have an increased frequency of esophageal contractions of high amplitude and a slightly increased frequency of simultaneous contractions when compared with a normal control population. 40 In addition, intraluminal US has been able to identify abnormal sustained contractions of the longitudinal smooth muscle in a subset of patients with chest pain. 41 How these contractions cause pain is unknown. One possible explanation is that pain occurs when high intramural esophageal tension resulting from altered motility inhibits blood flow to the esophagus for a critical period, i.e., myoischemia. Mackenzie and colleagues found that rates of esophageal Ruhrmeng are decreased after infusions of cold water into the esophagus of patients with symptomatic esophageal motility disorders as compared with age-matched controls. 42 Because the rate of Ruhrmeng after cold water infusion in patients with Raynaud phenomenon correlates directly with blood flow, the authors theorized that esophageal ischemia is the cause of the reduced rate of Ruhrmeng. None of the patients with a symptomatic esophageal motility disorder, however, experienced chest pain during the study. Furthermore, the extensive arterial and venous blood supply to the esophagus makes it unlikely that blood flow is compromised after even the most abnormal esophageal contractions. Complicating the relationship between esophageal chest pain and abnormal esophageal contractions is the consistent observation that most of these patients are asymptomatic when the contraction abnormalities are identified. In addition, amelioration of chest pain does not correlate predictably with a reduction in the amplitude of esophageal contractions. 43 The possibility exists that chest pain-associated motility changes represent an epiphenomenon of a chronic pain syndrome rather than the direct cause of the pain. In fact, experimentally induced stress can produce manometric changes and lower the tolerance to balloon or acid provocation in both normal subjects and patients with gastroesophageal reflux. 44 Other potential causes of esophageal chest pain include excitation of temperature receptors and luminal distension. Ingestion of hot or cold liquids can produce severe chest pain. This association was previously thought to be related to esophageal spasm, but subsequent studies have shown that cold-induced pain produces esophageal peristalsis and dilatation, not spasm. 45 This observation suggests that the cause of esophageal chest pain may be activation of stretch receptors by acute distension. Esophageal distension and pain are experienced during an acute food impaction, drinking carbonated beverages, in some patients, and dysfunction of the belch reflex. 46 In susceptible persons, esophageal chest pain can be reproduced by distension of an esophageal balloon to volumes lower than those that produce pain in asymptomatic persons. 47 Therefore, altered pain perception may contribute to the patient's reaction to a painful stimulus. Panic disorder is a commonly overlooked coexisting condition in patients with chest pain. 48 and should be sought specifically during history taking. The observation that anxiolytics and antidepressants can raise pain thresholds as well as improve mood states may explain why these medications may improve esophageal chest pain in the absence of manometric changes. 49. 50 Approach The approach to patients with esophageal chest pain has evolved over the years. 51 Before the esophagus is considered the cause of chest pain, a cardiac cause must be excluded. Appropriate testing may include an exercise stress test, non-invasive cardiac imaging, and coronary angiography. Insufficiency of coronary blood flow with normal-appearing epicoronary arteries, microvascular angina, has been suggested as a cause of chest pain in some patients. 52 Diagnosing microvascular angina on the basis of a therapeutic trial is difficult because the medications reported to improve this condition also have effects on the esophagus. However, the prognosis of most patients with microvascular angina is thought to be good. 53 The recognition that chest pain is often associated with GERD has been a major advance in our understanding of esophageal chest pain. Ambulatory pH testing can document pathologic amounts of acid reflux or a correlation between acid reflux and chest pain in up to 50% of patients in whom a cardiac cause has been excluded. 54 In addition, a trial of therapy with a PPI produces symptomatic improvement in many such patients. 55 The association between chest pain and GERD is easy to recognize when the patient has coexisting reflux symptoms but not so clear when typical reflux symptoms are absent. A 10 to 14-day trial of an oral PPI taken twice daily has been shown to be sensitive and specific for the diagnosis of esophageal chest pain when compared with ambulatory intraesophageal pH testing. 56 The results of a randomized placebo-controlled trial in 2013 support a trial of a PPI in primary care patients with chest pain, after cardiac disease has been excluded. 57 Chest pain may respond to gastric acid inhibition even if a coexisting motility disturbance is present. 58 If a patient fails this trial, the next practical approach may be a trial of agents such as imipramine or trazodone that raise the pain threshold. 59 Some authorities recommend esophageal testing with stationary manometry at this point to exclude a motility disorder and ambulatory pH testing to exclude gastroesophageal reflux unresponsive to the initial trial of the PPI therapy. Rarely, patients with chest pain will have a specific manometric disorder such as achalasia or distal spasm, but more frequently abnormalities are nonspecific and difficult to attribute to an individual patient's symptoms. The advent of a tube-free wireless system for gastroesophageal reflux monitoring has allowed a longer and more comfortable monitoring period, which increases the likelihood of observing a correlation between pain and an acid event. 60 If gastroesophageal reflux is confirmed by ambulatory pH testing, an additional trial of acid suppressive therapy is warranted. If a spastic or hypercontractile motility disorder is discovered on manometry, an attempt at lowering esophageal pressure with nitrates or a calcium channel blocker is appropriate, although some patients with chest pain and a motility disorder will respond better to agents directed at lowering visceral sensitivity. Surgery, myotomy, for patients with esophageal spasm and with chest pain predominant type 3 achalasia should be avoided, see Chapter 44. Heartburn and regurgitation. Heartburn, pyrosis, is one of the most common GI complaints in Western populations. 2 In fact, it is so common that many people assume it to be a normal part of life and fail to report the symptom to their healthcare providers. They seek relief with over-the-counter antacids, Indeed, heartburn accounts for most of the $1 billion/year sales of these non-prescription drugs. Despite its high prevalence, the term heartburn is frequently misunderstood. It has many synonyms, including indigestion, acid regurgitation, sour stomach, and bitter belching. The physician should listen for these descriptors if the patient does not volunteer a complaint of heartburn. A study from Europe has suggested that using a word picture description of a burning feeling rising from the stomach or lower chest up toward the neck increases the ability to identify patients with gastroesophageal reflux. 61 The burning sensation often begins inferiorly and radiates up the entire retrosternal area to the neck, occasionally to the back, and rarely into the arms. Heartburn due to gastroesophageal reflux of acid may be relieved, albeit only transiently, by ingestion of antacids, baking soda, or milk. Interestingly, the severity of esophageal damage, esophagitis or Barrett esophagus, does not correlate with the severity of heartburn, e.g., patients with severe heartburn may have a normal-appearing esophagus on endoscopy, and those with severe esophagitis or Barrett esophagus may at times have mild or even no symptoms. See chapters 46 and 47. 62 Heartburn is most frequently noted within 1 hour after eating, particularly after the largest meal of the day. Sugars, chocolate, onions, carminatives, and foods high in fat may aggravate heartburn by decreasing lower esophageal sphincter, lay, pressure. Other foods commonly associated with heartburn, e.g., citrus products, tomato-based foods, spicy foods, irritate the inflamed esophageal mucosa because of their acidity or high osmolarity. 63 Beverages, including citrus juices, soft drinks, coffee, and alcohol, may also cause heartburn. The relationship between alcohol and heartburn is complicated. It appears that most heartburn associated with alcohol is related to increased sensitivity to acid by loosening of tight junctions between esophageal epithelial cells, thereby allowing normal amounts of acid to reach deeper into the mucosa and produce symptoms. 64 Many patients have exacerbation of heartburn if they go to sleep shortly after a late meal or snack, and others note that their heartburn is more pronounced while they lie on their right side. 65 Weight gain frequently results in development of new symptoms of GERD and worsening of symptoms in patients with pre-existing GERD. 66 Activities that increase intra-abdominal pressure, e.g., bending over, straining at stool, lifting heavy objects, performing isometric exercises, may aggravate heartburn. Running may also aggravate heartburn, and stationary bike riding may be a better exercise for those with GERD. 33 Because nicotine and air swallowing reduce lay pressure, cigarette smoking exacerbates the symptoms of reflux. 67 Emotions, anxiety, fear, worry, may exacerbate heartburn by lowering visceral sensitivity thresholds rather than increasing the amount of gastroesophageal acid reflux. 68 Some patients with heartburn complain that certain drugs initiate or exacerbate their symptoms by reducing lay pressure and peristaltic contractions, e.g., theophylline, calcium channel blockers, or by irritating the inflamed esophagus, e.g., aspirin, other NSAIDs, bisphosphonates. Heartburn may be accompanied by the appearance of fluid in the mouth, either a bitter acidic material or a salty fluid. Regurgitation describes the return of bitter acidic fluid into the mouth and at times the effortless return of food, acid, or bilious material from the stomach. Regurgitation is more common at night or when the patient bends over. The absence of nausea, retching, and abdominal contractions suggests regurgitation rather than vomiting. See Chapter 15. Water brash is an uncommon and frequently misunderstood symptom that should be used to describe the sudden filling of the mouth with clear, slightly salty fluid. This fluid is not regurgitated material but is secreted from the salivary glands as part of a protective, vagally mediated reflex from the distal esophagus. 69 Regurgitation and symptoms similar to water brash can occur in patients with achalasia, who may be misdiagnosed as having GERD. Regurgitation must be distinguished from the syndrome of rumination, see Chapter 15. Rumination is a clinical diagnosis and is best described by the Rome 4 Consensus Committee diagnostic criteria. Patients must have persistent or recurrent regurgitation, not preceded by retching, of recently ingested food into the mouth, with subsequent remastication and swallowing. Supportive criteria include absence of nausea, cessation of the process when the regurgitated material becomes acidic, and content consisting of recognizable food with a pleasant taste in the regurgitant. 70 Rumination is essentially a diagnosis of exclusion when there is clinical suspicion. There have been reports of a fairly specific pattern often seen during prolonged manometry, although an episode must occur during the study for the manometric pattern to be helpful. 71 Patients with bulimia sometimes report regurgitation and may be mistakenly diagnosed as having GERD, see Chapter 9. Both rumination and bulimia may produce esophagitis, a positive ambulatory pH test, or both, thereby making the clinical differentiation even more challenging. Nocturnal reflux symptoms have special significance. In a survey of patients with frequent reflux symptoms, 74% reported nocturnal symptoms. 72 These nighttime symptoms interrupt sleep and health-related quality of life to a greater degree than daytime reflux symptoms alone. Patients who have prolonged reflux episodes at night are also at increased risk of complications of GERD, including severe reflux esophagitis and Barrett esophagus, see chapters 46 and 47. Pathophysiology. The physiologic mechanisms that produce heartburn remain poorly understood. Although reflux of gastric acid is most commonly associated with heartburn, the same symptom may be elicited by esophageal balloon distension 73, reflux of bile salts 74, and acid-induced motility disturbances. The best evidence that the pain mechanism is probably related to stimulation of mucosal chemoreceptors is the sensitivity of the esophagus to acid perfused into the esophagus and acid reflux demonstrated by monitoring pH. The location of these chemoreceptors is unknown. One suggestion is that the esophagus is sensitized by repeated acid exposure, resulting in the production of symptoms from smaller boluses after repeated exposure to acid. This hypersensitivity has been reported to resolve with gastric acid suppressive therapy. 75 The correlation between discrete episodes of acid reflux and symptoms, however, is poor. For example, postprandial gastroesophageal reflux is common in healthy people, but symptoms are uncommon. Intraesophageal pH monitoring of patients with endoscopic evidence of esophagitis typically shows excessive periods of acid reflux, but fewer than 20% of these reflux episodes are accompanied by symptoms. 76 Moreover, one-third of patients with Barrett esophagus, the most advanced form of GERD, are insensitive to acid. 77 As patients age, their sensitivity to acid in the esophagus seems to decline. This finding may explain the common observation that mucosal damage is fairly severe but symptoms are minimal in older patients with GERD. 78 Therefore, the development of symptoms must require more than esophageal contact with acid. Mucosal disruption and inflammation may be contributing factors, but on endoscopy the esophagus appears normal in most symptomatic patients. Other factors that possibly influence the occurrence of heartburn include the acid clearance mechanism, salivary bicarbonate concentration, volume of acid refluxed, as measured by the duration and proximal extent of reflux episodes, frequency of heartburn, and interaction of pepsin with acid, see Chapter 46. Studies in which acid reflux is monitored for more than 24 hours have demonstrated considerable daily variability in esophageal acid exposure. 79,80 As noted earlier, heartburn strongly suggests gastroesophageal acid reflux, but PUD, delayed gastric emptying, and even gallbladder disease can produce symptoms similar to those caused by reflux, see chapters 50, 53, and 65. Regurgitation is not quite as specific for acid reflux as heartburn, and the differential diagnosis of regurgitation should include an esophageal obstruction, e.g., ring, stricture, achalasia, or a gastric abnormality such as gastroparesis or outlet obstruction. Heartburn can also be a functional box 134 extraesophageal manifestations of GERD: asthma, chronic cough, excess mucus or phlegm, globus sensation, hoarseness, laryngitis, pulmonary fibrosis, sore throat symptom as discussed in the Rome 4 guidelines. 81 Functional heartburn is defined as retrosternal burning discomfort or pain refractory to optimal anti-secretory therapy in the absence of GERD, histopathologic mucosal abnormalities, major motor disorders, or structural explanations. Reflux hypersensitivity is the designation applied to patients with esophageal symptoms, heartburn or chest pain, who lack evidence of reflux on endoscopy, e.g., esophagitis, or an abnormal acid burden on reflux monitoring but experience symptoms with physiologic reflux. The approach to patients with heartburn and regurgitation is discussed extensively in Chapter 46. In brief, published guidelines support an initial trial of gastric acid suppressive therapy, generally with a PPI, as a diagnostic and therapeutic maneuver. 82 This concept is cost-effective but plagued by limitations in sensitivity and specificity. 83 If the cause of symptoms remains uncertain after a therapeutic trial, ambulatory intraesophageal pH testing is the best test to document pathologic esophageal acid exposure. Endoscopy of the esophagus is reserved for patients with symptoms suggestive of a complication, e.g., dysphagia, weight loss, signs of bleeding, but the predictive value of using a symptom profile to predict esophageal damage is questionable at best. Although not without controversy, most guidelines also suggest endoscopy to screen for Barrett esophagus in patients with chronic reflux symptoms. 84. The risk is particularly increased in white male, older, and obese persons. 85. 86 Guidelines as recent as 2012 have continued to challenge the utility of screening for Barrett esophagus, particularly in women. 87 Extraesophageal symptoms of gastroesophageal reflux disease. Extraesophageal symptoms of GERD are listed in box 13.4. Although these symptoms may be caused by esophageal motility disorders, they are most frequently associated with GERD. In patients with extraesophageal symptoms, the classic reflux symptoms of heartburn and regurgitation often are mild or absent. See Chapter 46. Gastroesophageal reflux is thought to cause chronic cough and other extraesophageal symptoms as a result of recurrent microaspiration of gastric contents, a vagally mediated neural reflex, or, in many patients, a combination of both. 88 Although bronchodilators reduce lay pressure, most persons with asthma have gastroesophageal reflux with or without bronchodilator therapy. In animal studies, instillation of small amounts of acid in the trachea or on the vocal cords 89 can produce marked changes in airway resistance, as well as vocal cord ulcers. Direct evidence for aspiration is more difficult to identify in adults and rests primarily on the presence of fat-filled macrophages in sputum. 90 Radioactivity in the lungs after a tracer is placed in the stomach overnight. 91 Increased pepsin levels in lung secretions. 92 And a high degree of esophageal or hypopharyngeal acid reflux recorded by 24-hour pH monitoring with dual probes. 93 Data from animal and human studies suggest that a neural reflex is another pathophysiologic basis for these symptoms. Acid perfusion into the distal esophagus increases airway resistance in all subjects, but the changes are most marked in patients with both asthma and heartburn. 94 Abnormal amounts of gastroesophageal acid reflux recorded by prolonged intraesophageal pH monitoring have been identified in 35% to 80% of asthmatic adults. 95 Symptoms that suggest reflux-induced asthma include the onset of wheezing in adulthood in the absence of a history of allergies or asthma, nocturnal cough, or wheezing. Worsening of asthma after meals, by exercise, or in the supine position, and asthma that is exacerbated by bronchodilators or is glucocorticoid dependent. In patients with reflux, symptoms strongly suggestive of aspiration include nocturnal cough and heartburn, recurrent pneumonia, unexplained fever, and an associated esophageal motility disorder. Silent aspiration after lung transplantation has been implicated as an important cause of declining graft function and even rejection. 96 In addition to reflux, significant esophageal dysmotility can occur in patients with more advanced pulmonary disease, including those recovering from lung transplantation. 97 Ear, nose, and throat complaints associated with gastroesophageal reflux include postnasal drip, voice changes, hoarseness, sore throat, persistent cough, otalgia, halitosis, dental erosion, and excessive salivation. Many patients with GERD complain of only head and neck symptoms. Examination of the vocal cords may help in evaluating patients with suspected acid reflux-related extraesophageal problems. Some patients have redness, hyperemia, and edema of the vocal cords and arytenoids. In more severe cases, vocal cord ulcers, granulomas, and even laryngeal cancer, all secondary to GERD, have been reported. Normal results of a laryngeal examination, however, are not incompatible with acid reflux-related extraesophageal symptoms, nor are the aforementioned laryngeal signs specific for a GERD-related pathogenesis. The options in a patient with suspected extraesophageal GERD are to study them with an ambulatory intraesophageal pH test or initiate a trial of therapy to confirm the diagnosis and treat the symptom, Fig. 13.2. Either approach is reasonable, but many experts favor an initial trial of acid suppressive therapy with a PPI twice daily. 98 Ambulatory pH testing is then reserved for those who fail the initial trial, although it is not clear whether pH testing should be done while the patient continues or after the patient discontinues acid suppressive therapy. See Chapter 46. Interpreting pH data in patients with extraesophageal symptoms and normal amounts of acid exposure is particularly challenging. Many studies have shown a poor correlation between reflux events and cough when cough is recorded by the patient, but a better correlation when acoustic cough monitoring, an experimental yet to be approved technology, is used to quantify and time the cough episodes. 99 The association between gastroesophageal reflux and extraesophageal symptoms, particularly laryngeal symptoms, has been challenged. In one study, pH monitoring of the hypopharynx and proximal and distal esophagus was performed in patients with presumed gastroesophageal acid reflux-related endoscopic laryngeal findings. 100 An abnormal result was noted in only 15% of hypopharyngeal probes, 9% of proximal esophageal probes, and 29% of distal esophageal probes, indicating that most patients, 70%, with symptoms and signs of laryngeal reflux do not have documentable abnormal acid exposure. That preliminary study was followed by a randomized placebo-controlled trial of esomeprazole, 40 mg twice daily, in the same patients, with response rates of 42% in those treated with esomeprazole and 46% in those treated with placebo. 101 A randomized controlled trial of therapy with a PPI in asthmatics produced similar results. 102 Despite the contradictory data, a trial of PPI therapy in patients with symptoms suggestive of extraesophageal GERD is reasonable, but the patient and physician should not be surprised if this therapy fails. Full references for this chapter can be found on vexpertconsult.com. Approach to exclusion of an underlying disease varies, depending on the symptom under evaluation, see text. A PPI is given before breakfast and before the evening meal. The duration of the trial depends on the symptom. For example, a 10 to 14-day trial may be sufficient for non-cardiac chest pain, whereas a 3-month trial may be needed for chronic cough.